Hello guys, welcome back to the channel. So today is 15th of August and today is Independence Day. So yesterday my exams are over and today I just wanted to do rest but I failed to do. So I decided to study a small topic and I did a revision of RH incompatibility. So basically what it is related to the blood related things, like we are having A positive, B positive, A negative, AB positive, such kind of blood groups we are having with. But there is a one complication in related to the pregnancy and babies. So basically what happens the when we see the red blood cells having the D antigen on the surface of the red blood cells and the antibodies formed against that antigen, so it will lead to the destruction of the RBCs in the next pregnancy, and it kills the red blood cells of the fetus. So that's where the severe anemia happens into the baby. So basically what happens, there is a anti Rh antigen present on the blood cells, and when there is a condition where the mother is Rh negative and the fetus is Rh positive, and accidentally there is a mixing of both bloods, like when the baby is Rh positive blood mixed with Rh negative blood of the mother, then the mother forms the anti D, means anti D antigen against antibodies against antigen D. So that antibodies kills the baby's red blood cells, which leads to the hemolytic anemia. Hemolytic means hemolysis, means lysis of the blood. So severe anemia happens, and we will clearly see the what the actual pathogenesis is when the blood of the fetus enters to the mother. Even the 0.1 ml of a blood is capable to sensitize the mother towards the fetal blood. So when the mother fetal blood mixes with the maternal blood, then antibodies forms which of IgM nature, and after 6 months the class switching occurs and it turns into the IgG antibodies, which are capable to cross the placenta and act to the fetal blood. So this antibodies forms and lead to the hemolysis of the RBCs in the fetus, and actually hemolysis and the hemolytic anemia occurs. So there are the many complications after the severe anemia, like placentomegaly, which leads to the what can I say, pregnancy induced hypertension. Then the excess destruction of the RBC. You can search that the destruction of RBC lead to the hyperbilirubinemia, and the get level above 20 gram per deciliter, 20 I think 20 milligram per deciliter can crosses the bilirubin to the blood-brain barrier, which causes the seizures, complications, and convulsions, and many other neurological disorders, which are characterized by the kernicterus, and many other complications such as erythroblastosis fetalis, hydrops fetalis, and other complications like polyhydramnios. Such kind of complications we will see in detail. I will just explain the pathogenesis. Actually, what happens when the severe anemia happens? So basically, what happens due to hemolysis, the serum bilirubin levels increases, which lead to the yellowish discoloration of the skin, sclera, and the mucosal membrane. Which and when the levels of the bilirubin rises above 20 milligram per deciliter, then it crosses the blood-brain barrier and started accumulated in the basal ganglia of the brain. So that causes the all neurological symptoms like convulsions, tremors, seizures, or many other neurological complications which are characterized by the kernicterus. The next complication is the erythroblastosis fetalis. So what actually it is? When there is a severe anemia, our blood is unable to compensate all the oxygen demand, nutrition demand. So our body needs more RBC. That's why the compensatory mechanism starts, which leads to the compensatory extramedullary hematopoiesis. So which leads to the hepatosplenomegaly. Means the liver is hypertrophy more than the spleen, and due to this the basically when the in fetus bone marrow is not producing RBCs that much, but the liver, spleen, this organ forms the RBC. So the excessive load on the spleen and the liver leads to the damage and excessive formation of the RBCs occurs. And if the production of the RBC is raised, so the immature RBCs are released into the blood. So that which leads to the immature RBCs in the actual blood flow. And the immature RBCs are also known as the erythroblast. That's why the stage is known as the erythroblastosis fetalis. The next complication of the severe anemia is the hydrops fetalis. So basically what happens, due to compensatory mechanism, the hyperdynamic circulation occurs, which leads to the high output cardiac failure. So due to this, the venous congestion occurs, and due to congestion, the pulmonary edema, ascites, such kind of things occurs. Peripheral edema also occurs, which actually what happens, the fluid accumulates in the cavities, which is also known as hydro. Water is also known as the hydro. So that's why the stage is called as the hydrops fetalis. Another complication of the severe anemia is the pregnancy-induced hypertension. So basically, what happens when anemia occurs and the demand of oxygen increases, then the placenta-megaly occurs, means the size of the placenta increases, which compresses the vessels. So the hypertension occurs. What actually, the BP increases, which also known as the hypertension. So when the placenta size increases, it leads to the extra centripetal force on the arteries, and the blood pressure is actually the pressure exerted by the blood on the vessel wall. So that's why the pregnancy-induced hypertension is the major complication of that severe anemia. And the one more complication is there, which is the polyhydramnios, which means the amniotic cavity there is an excessive fluid. So basically what happens, due to compensatory hematopoietic mechanism, hepatic dysfunction occurs, as I explained earlier. So it leads to hepatic functions are the synthesis of the proteins and many other metabolic functions, and detoxification functions are the liver is having. But one more important function is to prepare albumin protein, which occurs in the liver. So basically albumin does the regulation of the osmotic pressure into the blood osmotic pressure. So when the synthesis of the albumin decreases, then the osmotic pressure outside the vessel increases. That's why the fluid from the blood vessels comes out to the other tissue. So in kidney, the GFR, glomerular filtration rate, increases. That's why the urinary output increases, and this urine output, when it increases, then it is released into the amniotic cavity in the pregnancy. That's why the fluid outside the baby increases, and it causes the polyhydramnios. So guys, this was the complications of the RH incompatibility. So the next point is how to treat. So basically, the one drug is given to given in this case, which is the antibodies, which neutralizes the fetal RBCs when they are mixed with the maternal blood. 300 microgram of the anti-D is given to the mother within 72 hours after the delivery to neutralize the blood. So 300 microgram of anti-D neutralizes the 15 ml of the fetal RBC and 30 ml of the fetal blood. So it is sufficient, but how can we calculate the dose? So there is the acid elution test, which gives the quantitative analysis of how much amount of anti-D required. So basically this test is not done in the general practice. We use only 300 microgram of anti-D, and yes, this is the one point about the anti-D. So I will explain how it actually works, and I will describe the protocol. Means what can I say? How we actually give this drug to the mother. So if the two tests are there to test the sensitivity of a mother towards the fetal blood. So when mother is sensitized with the fluid, fetal blood, then it comes out to ICT positive, means indirect comb test positive, and if not, then it is not sensitized. So basically, I will deal with the negative cases first and then the positive test. So when at the 28th week of the gestation, we do the indirect comb test in the maternal blood, and if we get the negative result, still we use the prophylaxis dose of 300 microgram, um, and deliver the baby, which is an antepartum prophylaxis procedure. And after delivery, again we give the prophylactic dose when even the 0.1 ml of blood can sensitize the mother. So to avoid the risk of RH incompatibility, we use the prophylactic dose of the RH antibodies. So again, after the delivery of the RH positive baby, we use 300 microgram of antibodies. Fine. Another one case is when the RH positive, means indirect home test positive result, mother comes to the OPD. Then we perform. First of all, we perform ICT test at the 28th week of the period of gestation, and when it comes to the positive, then we check the antibody titer level. In this, we check the how much amount of antibodies are there for the fetal blood. If the ratio is more than 1:16, then we check for the fetal anemia with Dopplers. In this, we check peak systolic velocity. So, in Doppler method, there is a one machine, Doppler's machine, which gives a PSV, means the peak systolic velocity, if of a middle cerebral artery. If it is greater than the 1.5 multiple of a median, then it is considered as a significant anemia. And if the gestation period is reached above 34 weeks of a gestation period, then we can deliver the baby. And if the gestation period is below 34 weeks, then we give corticosteroids and to the baby to maintain the pregnancy. And after after that, we do the cordocentesis to analyze what the actual hemoglobin count. And if the hemoglobin count is below 8 gram per deciliter, which is the severe anemia to the fetal baby, then we do the intrauterine transfusion. So it leads to the, and so that we can continue the pregnancy, and after 34 weeks we can safely deliver the baby. So basically this was the protocol. There is many more content with me. So basically, one important point is there for you. What actually the hydrocephalus it is. So fluid in the more than two body cavities, like ascites, pleural effusion, pericardial effusion, and the scalp edema. Scalp edema, when we see under the USG, it gives the halo sign, which is the Buddha sign. If you search on the USG in the Google halo sign, so then it will show like and the baby skull is here, the fluid between the scalp is having so much distance in between them, so it looks like something is coming back from the fetus and the skull. So it is like very divine, looking like a phenomena. But yeah, this is Buddha sign, also known as halo sign. Another one, many content I am having with, but it is not necessary. Yes. So that's for today, and this is the point I have did today, and yes, the exams are over, but still I did this point. So that's for today. Thanks for watching. I will catch you in the next one.